Esse é o grande round do Hospital de Clínicas de Porto Alegre, em colaboração com a Faculdade de Medicina da Universidade Federal do Rio Grande do Sul. O encontro de hoje será sobre implementação de novos conceitos em medicina perioperatória. Trata-se de um encontro internacional que será, portanto, conduzido em inglês e, em sequência, estarei fazendo a conversão da língua. Welcome to the HCPA Grand Round. Today the meeting will address new concepts in perioperative medicine. We'll have the chance to hear and exchange experience with the people who are leading the way in UK, Canada, and Brazil. The meeting was designed for 3 short presentations, followed by a panel discussion. Our 3 guest speakers are Dr. Rupert Pearce, Queen Mary University, London, UK, Dr. Flavia Borges, McMaster University, Hamilton, Canada, Dr. Luciana Cadori Stefani, HCPA, Porto Alegre, Brazil. The panel discussion will count on the participation of Dr. Nadine Klossel, Professor of Cardiology and CEO of HCPA, Dr. Karini Polanczyk, Professor of Cardiology at HCPA, and Dr. Miguel Dora, Professor and Head of Internal Medicine Section at HCPA. Now I will ask Dr. Luciana Stefani to welcome and better introduce our guest speakers. Please, Luciana, go ahead.
Good morning. It's a great pleasure to be here. And I'd like to introduce to you Professor Rupert Pearce. Professor Pearce is a specialist in intensive care and anesthesiology and works as a professor at Queen Mary University of London. He's a well-recognized leader in perioperative medicine all over the world, and he has a lot of experience leading several international epidemiological projects and also large multicenter randomized trials. Also, he's committed with outcomes of surgical patients around the world, especially in low middle-income countries. And recently, his group at Queen Mary has been awarded an impressive funding for research projects to improve post-surgical outcomes in Africa. So we are very proud to have been working with him in some local international projects. And we are very happy to have you here, Rupert, today. I know that your agenda is very, very busy, so we thank you so much. And we hope you enjoy being with us today.
Dr. Nadine will introduce Dr. Flavia Borges, please. Nadine.
Thank you, Dr. Fleck. It's a pleasure to speak a little bit about Flavia. Flavia is a former medicine student in our university and also a former resident from Hospital de Clínicas de Porto Alegre. She did her graduate studies, master's, and both PhD in our university under Dr. Karini Polanczyk supervision. So she's been a long time friend of all of us, and also is keeping the doors open to more fellows and residents to go to Hamilton, where she is now a professor at the Department of Medicine at the Perioperative Care Division at McMaster University, and we are very proud of Flavia's trajectory in the last few years. She's been a leading investigator in some papers and studies in the area, and she has worked a lot with Dr. Devereux in the last few years, and is really opening a new channel, a new research area, very important in the perioperative management. So it's really a pleasure to have Flavia here to speak about how she's building this working team and the patient care around those patients, which are very challenging for all of us. So I think it's going to be a very important activity this morning here. Again, Flavia, a pleasure to have you here with us, and we are eager to hear you. So, Luciana, are we starting with Flavia?
Yes.
Okay, hi everyone, thanks so much. I'll start sharing my screen. I'll close my video for now, and I'll share my screen. So just again there. I want to be sure before I start that you're all seeing my full screen.
It's perfect, Flavia.
Okay, wonderful. So thank you, Nadine, for the kind introduction, and Luciana for the invitation to be here with all of you today. It's my pleasure to talk a little bit about building an effective perioperative team, the experience from McMaster University. So just to start, I have a little bit of conflict of interest, as Nadine said, because I did all my training at Hospital de Clínicas de Porto Alegre. It's my main Brazilian home, I would say. And I did my master's PhD at URGS. And now I did my postdoc at PHRI, and now I'm faculty at McMaster University. So for me, it would be natural to try to keep building collaboration and to share my experience and also offer some opportunities for further training for whoever would be interested in. So the learning objectives for this talk are to understand the traditional perioperative care model challenges, the steps to implement a perioperative care program, and how to get buy-in from your medical team, as well as to discuss a little bit approach based on the perioperative care program at McMaster, discussing about the clinical care and also about research collaboration. Globally, greater than 300 million adults undergo non-cardiac surgery per year. In the first 30 years after surgery, greater than 10 million will suffer a cardiovascular complication. Greater than 15 million will suffer bleeding independently associated with mortality, and 10 million will suffer infection and sepsis. 2% will die within 30 days after an inpatient surgery. And now, perioperative mortality is the third leading cause of death in the United States. McMaster University in Hamilton, Ontario, has 4 university hospitals with different focus, but perioperative care was based on a traditional approach. So we had several independent teams doing perioperative care, named surgery, anesthesia, internal medicine, cardiology, geriatrics, and thrombosis. And the clinical care was led by the surgeon, where he would involve other specialties based on his expert opinion. So if you look into this figure, I just built a traditional model within the 3 phases of perioperative care: the pre-operative outpatient assessment, the inpatient phase, and the post-discharge as an outpatient. So the traditional model, usually the surgeon sees the patient together with anesthesia, and they involve for high-risk patients, either internal medicine, cardiology, or thrombosis consults, or the 3 of them before a patient proceeds to surgery, depending on the complexity of the surgery and the patient. And then during the inpatient phase, usually the surgeon would see the patient in the OR and the recovery area together with the anesthesia, will follow throughout hospitalization, and will just call other medical teams if any complication should occur, and they will consult multiple specialties depending on the complication. And then after discharge, the surgeon will see the patient in the clinic, also refer to the family physician, and involve multiple specialties depending on the clinical complication that happened after surgery for follow-up. So just illustrate with a case. This is an 89-year-old woman. She had Alzheimer's disease, living at home. She had peripheral arterial disease, hypertension, and dyslipidemia. She had the right side hip fracture after a mechanical fall. And post-operative day 1, very early in the morning, her systolic blood pressure was 70. Nurse called the resident that is on call. He's in the OR, and he tells just to run 1 liter of Ringer, and he would assess as soon as his surgery is finished. After 1 hour, the nurse called him back again, saying the blood pressure is better, but still in the 80s. And then he tells her, run more 500 mLs of Ringers, and I will be there as soon as possible. Then the patient starts progressing with hypoxia. She goes in up titrating oxygen up to a ventimask 50%. Then she has elevated JVP, diffuse crackles to both lungs. And when the resident get there, few hours after, I would say 3-4 hours after, the patient is clearly congested and he needs to treat with IV Lasix. This is the ECG at admission, just very brief. Patient has a normal sinus rhythm, and as you can appreciate, there is no ischemic signs of myocardial ischemia. However, when the resident gets there and he orders an ECG, then you can appreciate that from V3 to V6, there's some ST depression, a sign of anterolateral ischemia. When he gets the results for the troponins that he ordered, you can see in this table that on post-operative day 1, once he assessed the patient, the troponin, which the normal level was 45, it's higher than 2,000. In the evening, it peaks to 6,000, and then only in the following day, it starts dropping to 4,000. The resident, when he sees the troponin plus the ECG changes, he starts a bolus of aspirin plus clopidogrel and then heparin IV. Then he calls cardiology. Patient is transferred to ICU. Patient ends up having a major bleeding that was caused likely by the triple therapy associated with the recent surgery for a hip fracture. So in the traditional model, the surgeons, they are busy in the operating rooms, and this limits their ability to closely monitor and titrate medical therapy. And delays in recognizing and managing inpatient complications may happen. There are also multiple post-operative complications, likely pulmonary embolism, myocardial infarction, stroke, sepsis, and atrial fibrillation are the most common. And medical therapy keeps advancing very rapidly for those complications. And perioperative clinical management is different from the non-operative setting. So in this case that I presented, perioperative MI, we know that has a complex physiopathology, and it's very difficult to differentiate type 1, that's a thrombotic event, versus a supply-demand mismatch event, type 2 event. And most cardiology trials, they exclude those patients that recently went under surgery, and usually triple therapy in this population increase the risk of bleeding. Here's another example of one of the trials that we recently published in the BMJ last year, where we look into post-discharge virtual care with remote automated monitoring technology versus the standard of care. This was an RCT that we included over 900 patients, and they were 40 years old or greater, being discharged after non-elective surgery. So this was semi-urgent, urgent surgery in 9 centers in Ontario and Alberta, and we ran this trial during the COVID pandemic. I just want to call attention to this table where we look into 30-day post-operative outcomes for semi-urgent, urgent surgery in the standard of care column. So here you can see that with our current standard of care of post-operative follow-up, we had about 27% acute hospital care within 30 days, including 30% of hospital readmissions and 24% of emergent department visits. Also, when we look into this table, looking into the secondary outcomes in the trial, I want to call the attention to the standard care group for the detection of medication error. It happened in 6% of the patients, and 4% had the correction of the medication error. When you look into our virtual care group, we had 30% detection of medication error, and 28% of those medications error were corrected. So those were patients where they had their aspirin hold for the surgery and they were never resumed, and they had coronary artery disease, or where they had ACE and ARBs that were hold because of hypotension during surgery and they never resumed these chronic medications. Also patients that had their insulin dose cut and then they were not reestablished. So definitely in the standard of care, we have issues with medication reconciliation on hospital discharge. So just to summarize, the traditional model is associated with fragmented care, sometimes with patient dissatisfaction based on our surveys, with high readmission rates. Patients are typically seen by the surgeon only 4 or 8 weeks after surgery, depending on the type of surgery and the patient complications. There are issues with medication reconciliation, elevated cost, challenges for integrated education and research projects, and also lack of ownership when disruptions in clinical care or complications occur. So we came up with this new model with the perioperative care program, where the strategic plan was focusing on a patient-centered goal with the foundation on multidisciplinary integrated care, and also focus on communication and collaboration. And the goals of the program were to provide clinical support to the surgical population to reduce length of hospital stay and promote early discharges, to reduce post-operative rehospitalizations and emergency department visits, to improve patient experience and increase accessibility to care, and also scale and sustain the best practices. So in this model, we propose within McMaster University a new discipline, a new division of perioperative care physicians, that they were dedicated to the management of perioperative patients. So we created a new division within the Department of Medicine, and those physicians, they should come from anesthesiology, medicine, and surgery. And we have a dedicated training in perioperative medicine. So we have a program where residents from surgery, anesthesia, and internal medicine, they do usual rotation and elective rotations monthly with us, as well as the clerks from the university. And then we have the fellowship program that can be either 6 months or 1 year or even more if the fellows do, aside from the clinical work, if they want to do masters and PhD and join like a research training together with their fellowship. So we have a group of dedicated available physicians 24/7 in the hospital that are focused in perioperative care. And we build a core team to lead and integrate also perioperative research in clinical practice. So we started this plan seeking institutional support. So it's key that you share the plan with your institution and present evidence-based data on potential integrated and shared care model benefits. You have to define the high-risk surgical population you want to focus on and build a multidisciplinary clinical care team and establish collaboration between all stakeholders, including the surgeons group, the anesthesia, all the clinical specialties, mainly internal medicine, cardiology, thrombosis, and also the nurses and managers. So here's just one example of a systematic review meta-analysis that look into shared care models for hip fracture patients. They look into 18 studies, including more than 9,000 patients, and they compare routine geriatric consultation on the ward-to-ward versus patients being admitted to the geriatric ward with only orthopedic consultation, or a shared care model where both teams would round together and see the patients together in an orthogeriatric ward. And this shared care model was associated with improved outcomes, meaning decrease on 40% in hospital mortality, decrease in long-term mortality with a hazard ratio of 0.83, and also decrease in length of hospital stay. So in order to get buy-in from the medical team, it's very important to involve physicians in the conception of the program, provide opportunity for feedback, engage physicians group in building a common clinical care approach, and also provide opportunity for additional training. So we built together with Dr. Devereaux and Dr. Amin Patel, the Society of Perioperative Research and Care, which is a forum that we have monthly journal clubs on main topics in perioperative medicine. We have weekly case rounds where we discuss challenging cases with the surgical and anesthesia group every week. We also have the Perioperative Care Congress annually to keep everybody updated in the most recent guidelines and also trials that were published within the last year. And we build internally at McMaster guidelines and protocols for the management of post-operative complications. And basically, we follow perioperative Canadian guidelines. Also, it's important to establish champions from multiple areas, including surgeons, nursing, anesthesia, internal medicine, cardiology, thrombosis, and we have a champion also from infectious disease. So the integrated model, it's a unique clinical pathway to assess patients in different scenarios. And we have a perioperative care team 24/7, either in the inpatient service. So we have a team with the staff, fellows, residents, and students. And we also have an outpatient service where we do virtual care and the post-operative clinic. So basically, when the surgeon sees the patient together with the anesthesia in their first approach, the high-risk patients, they send to our clinic, which is called Medical Optimization Clinic. We do pre-operative assessment and optimize patients for surgery. And then as soon as the surgeons finish the surgery and patients go to recovery area, all patients that we saw in our clinic, we have a system that flags those patients to us. We go to the recovery area, the PACU, and we see the patient right after, within 1 hour after the surgery. We already check how the surgery went, if there were any complications, if the patient is safe to go to the ward, or if they will need ICU bed or telemetry. We put the orders for troponins after surgery for the patients that would qualify, and we follow all patients even before they develop any post-operative complications throughout their admission together with the surgeons. And if any issues should occur, then we send them to the post-operative clinic. And also, even for patients that never had any complication, we offer the option for virtual care. So the post-operative virtual care outpatient is basically that patients are discharged with a tablet computer and a kit that can monitor vitals, weight, and take a wound picture every day. And then the nurses in the nurse station, they will receive the results of the vitals remotely. Patients will complete a recovery survey. They will call the nurses if they have any issues. Otherwise, they have scheduled calls with the nurses, day 1, 3, 7, and 14. And also we have a day 1 and 14 call with the perioperative physician on call. And all those calls, we focus on pain, on mobility, on teaching the wound care, and also to prevent any further complications. And we do the medication reconciliation, smoking cessation, etc. So what is interesting at McMaster is that we are able to integrate clinical care and research. So I just put here some few examples of trials that we published in the last 3-4 years. The PVC ramp that I just presented, that was the virtual care throughout the pandemic. Also studies that Carisi participate as a PI that we published in the New England earlier this year for the cardiac surgery and troponin monitoring, the vision study in JAMA, and last month we published together with Luciana, that was the site PI at Hospital de Clínicas, and Carisi, the POISE-3 first paper on tranexamic acid on patients undergoing non-cardiac surgery. So for all those trials, our site at McMaster was the top recruiter, meaning that every patient that we see in the clinic or within inpatient service, if they qualify for any of our trials, we always offer the patients to participate in research. And usually we are the top recruiters in those trials because we have an integrated team that sees clinical and research patients at the same time, and we follow in our clinic. So to finalize, of course, we have several challenges, and one of them is to ensure physician engagement and interdisciplinary collaboration, and also to establish a sustainable virtual care model. My take-home messages are that perioperative medicine is a collaborative discipline, and we should follow the shared care model and try to integrate all phases of perioperative care and all teams involved in patients' care. This requires a dedicated team to improve patient outcomes, and we should also integrate clinical research to advance the medical knowledge. So, just to finalize, thank you everyone for listening to me. I'll leave my email if you have any further comments or if you want to collaborate. And here, some names of very important people that participate in my trajectory. Many of them are on this call: Professora Carisi, Nadine, Luciana, Miguel Dora, and my colleagues from internal medicine that all collaborated for my career, as well as my team at PDRI, led by Dr. Devereux and Dr. Patel, Tandon Conning, Dr. Marcucci, Brandari, Jessica Vincent, Valerie Hiver, and Shirley Pettit. So thank you so much. And I'll stop sharing. I'll be happy to take any questions after the next panel.
Please, Dr. Pierce, we can go ahead.
Thank you. Flavia, that was an absolutely fantastic talk. I'm going to try and come close, but I fear I won't be able to, but here goes. So, I mean, I think that's a really fantastic description of perioperative medicine from a Canadian perspective, and I strongly agree with all the principles you've described there. So hopefully, at least that'll make my job easy. So I've been asked to talk a little bit about perioperative medicine. It's very kind of you to invite me. Really proud to have the opportunity to collaborate with colleagues in Brazil. And you guys are doing lots of great stuff, so it's fantastic to see you go from strength to strength. I do have some disclosures which I've listed here very briefly. So this is the hospital where I work. This is called the Royal London Hospital. It's in East London, which is a place called Whitechapel, quite famous if you've heard of Jack the Ripper, a famous criminal, which will give you some idea of the fact that it's quite an income-deprived area. And if you zoom out, you can see in the foreground Tower Bridge and HMS Belfast and the Tower of London. And of course, we're quite close to some of the wealthiest real estate in the UK, not only the UK, but Europe, the whole world. But on the other side, there are some of the most income-deprived areas of the UK as well. So we have a very interesting population that we serve. And I think in some ways that's similar in Brazil. I realize you have some very wealthy people in Brazil, but you also have a huge disparity with some very, very income-deprived people as well. And that creates a lot of challenges, variation in the quality of primary care. And that means that types of people that come to hospital for surgery can be very challenging, in that often what you see is people that come to surgery who haven't had great primary care only arrive at the hospital when there's something that is unfixable. And that might be a cancer, it might be a fracture, it might be an ischemic event, or whatever it might be. And so you often then find that those patients arrive with some very significant comorbidities. Maybe the patient's quite old as well. So really, if you think about surgery as a treatment, if surgery as a public health intervention is going to be effective, it needs to have as few complications as possible. As few things need to go wrong. When surgery goes wrong, it's expensive and it's very bad for the patient. So it's in the interests of both the healthcare system and in the interest of the patient that surgery should go right as successfully as possible. The most common problems are not actually failure of surgery or anaesthetist to do a good job. It's off-target complications like myocardial infarction that Flavia highlighted, or respiratory complications, acute kidney injury, and so on. And so you can define perioperative medicine in lots of ways, but I define it as the prevention and the treatment of harm resulting from the tissue injury of surgery, but also of anesthesia, because anesthesia is not without harm as well. So why perioperative medicine? Why should we do this thing that sounds like a big effort? We need to be collaborative across lots of different specialties, as Flavia points out, physicians, surgeons, anaesthetists, intensivists, and so on. Why should we do all of this? It sounds like a lot of effort. Well, again, Flavia's pointed out the sheer massive number of people who have surgery. And although we don't know exactly how many people die after surgery, if you assume a conservative estimate of a 1% mortality, that means 3 million people are dying every year. That's a lot of people. But the problem is that the denominator is massive. So you need to expose a very large number of people to a change in care to affect an improvement in outcome. And that's really the challenge of perioperative medicine. Either we need to enrich the population and focus in on the highest risk patients, or we need to find very economic and efficient interventions that could be exposed to the entire population. And that's the puzzle we're trying to solve here. We know that certainly in high-income countries, and I suspect all countries actually, that we're offering surgery to older and older and older people. And certainly in the United Kingdom, there are patients being offered surgery today who 20 years ago would have been considered too high risk, and they would have been given more conservative treatment options, whereas now they're offered a surgical treatment, which means that you have more patients who are older with comorbid disease, you have more patients having complications, the cost of the surgery, the resource demands on intensive care and perioperative care are much, much higher, and we're not equipping our healthcare system to deal with this patient. We're just blindly walking into this population without really strategically building the infrastructure that those patients need to deliver great care. If you look at comorbidities, this is some data from my colleague Alex Fowler, you can see that different comorbid diseases have very different impacts on post-operative outcomes, not only in the short term, but also in the long term. But I want to highlight three that appear to be very important, and that's dementia, cancer, and cardiac failure. Now, obviously, surgery is commonly a treatment for cancer, but in the UK population, 1 in 3 of those patients will be dead in 2 years. What are we trying to achieve with the surgery? What are we trying to do? Surgery is supposed to improve quality of life, quantity of life, or both. So are we sure we're achieving that? Dementia, 1 in 2 patients dead within 2 years. But do we systematically screen our patients for dementia? And do we tell them that they have a 1 in 2 chance of being dead in 2 years? Would that impact their decision to have surgery? I don't know. I think that the answers are different in different countries and different hospitals, but certainly something important to think about. So I'm very focused on the high-risk surgical patient. These are people having major surgery. They're usually older. They commonly have comorbid disease, and a lot of them have surgery as an emergency, in particular in those countries where primary care, community care isn't that great. So the patient often ends up resorting to secondary care when things get really bad. If we look at complications amongst these patients, we can see very quickly that those patients who develop complications, even after risk adjustment for other diseases and for age, they will have a much lower long-term survival. And even something as simple as a wound infection is associated with poor long-term survival. Now we can talk about confounding and unmeasured confounding, whether these patients would have died anyway. But I think the message is, if you see a patient who's had a post-operative complication, they're in a different category. Are we treating them differently? Are we thinking about just treating that complication and sending them home? Or are we thinking about how we can maximize their long-term survival and benefit from surgery? And I suspect the answer to that second question is no. Not in very many hospitals in any case. These are data looking at surgery from a primary care perspective in the UK. And basically, we're looking at how often patients come into contact with healthcare before surgery and then after. And if you look at the purple strata in the top there, you can see that this is the highest risk group, and they will have a significant increase in healthcare encounters after surgery. Even after they've been sent home from hospital, they're still going to see the primary care physician or the primary care nurse, or they're coming back to hospital for further clinic visits, or whatever it might be. And yet 1 in 5 of them will be dead in 2 years. So these patients aren't having surgery, getting fixed, and then living their lives. And that's what most of them are expecting to happen. They think that surgery will fix their problem, it will fix their pain in their hip, it will fix their cancer, and that they'll go home and live like they did before. But in most cases, they won't. They'll need much more healthcare than they did before surgery, and a lot of them will die. And this is a very, very common story, and we're not really listening to the narrative on this. We're not really yet ready to hear how common that story is. And I think we need a conversation with our society about that. I would also say that things in low and middle income countries can be very, very different indeed. And this is some work led by Bruce Pickard in Cape Town in South Africa, looking at surgical outcomes in Africa and showing that although the patients are younger, have a lower ASA score, they're twice as likely to die after surgery compared to the global average. And that's obviously a real problem. But perioperative medicine in Africa is going to look very different to perioperative medicine in the UK. And I think, again, both of those will be different to perioperative medicine in Brazil, where you've got a much more mixed population, as I say, of some very, very poor people, but also some very wealthy people. You've got quite high volume surgical systems compared to Africa, but you've got much higher burden of comorbid disease than somewhere like the UK or Europe. And so the challenge in Brazil will be analogous. You can compare things to what we do, but will need to be tailored and made to fit with the population that you care for. And that's a challenge for Brazil. So hopefully that's persuaded you why. Well, what would we do? Flavia has summarized this beautifully. But I think the first thing I would say is think about why the problem's happening. The acute harm is characterized by inflammation. Whether that's sepsis or trauma, you know that they're going to have a lot of systemic inflammation, but actually also surgery has systemic inflammation. It may not be as significant as a polytrauma or a severe sepsis, but it's still there. And that's why in the data that Flavia is presenting, you see the same pattern of organ injury that you see in sepsis and trauma. You see it in surgery. You see myocardial injury and so on in the same way. So the surgical patients get acute kidney injury, it's inflammatory, acute lung injury, it's inflammatory myocardial injury, polyneuropathy, myopathy, delirium. These are all things that I see in intensive care. We see the same pattern, but in surgical patients, it's not as bad. So it's how we think about that critical care model. Now, where my analysis would differ from some others around the country, around the world, sorry, that would see these as organ-specific diseases, I think of this as a whole body organ system problem. And if you look for the problem, you will find it. And myocardial injury is very striking because we have a fantastic biomarker to detect it in terms of troponin, whereas we don't have those biomarkers at the same degree for the other inflammatory problems. And that may affect our perception of the importance of myocardial injury, and it is very important, but there may be other very important things too. If you look at acute kidney injury, for example, you can see that the worse acute kidney injury is, the worse the short-term mortality, but also the long-term mortality, and that separation continues for many years after surgery. So the association, or possibly even the impact, of poor surgical outcomes is very, very substantial. We don't know whether this is the patient, whether they were going to die anyway, whether their kidneys were going to fail anyway, or whether it's the surgery or a combination of both. But what we do know is that when you see a patient who is at risk of these problems, it's an opportunity. It's an opportunity to change how we treat them. And it's an opportunity that currently is missed, that we can do something about. And I'll give you an example here. So say you've got a patient with a little bit of chronic kidney disease, quite mild. CKD puts you at risk of acute kidney injury. Maybe you have a pneumonia or a surgery, you get acute kidney injury. The creatinine goes up, it comes down again, but actually the kidney has lost nephrons. It's not the same kidney it was before, even if the creatinine went back to normal. So the patient progresses to CKD stage 2, more at risk of acute kidney injury. Maybe they have major surgery this time, they have another episode of AKI, and so on, until they end up in end-stage renal failure and need dialysis. Now, obviously not every patient has that experience, but as a model of disease, this stepwise acute harm that's associated with surgery, with sepsis, with trauma, is a very important cause of long-term disease. And it's not a recognized cause of long-term disease. If you ask your medical student, give me 3 causes of chronic kidney disease, they'll say hypertension, they'll say diabetes, maybe glomerulonephritis, but they won't say acute kidney injury. But acute kidney injury is probably a very important cause of chronic kidney disease, because we're not interlocking the idea of acute harm as a cause of long-term harm. And surgery, given the sheer volume of patients, is the biggest risk and also opportunity to prevent that acute harm. So how are we going to solve this problem? Well, you know, we, as again Flavia said, we need to think about before surgery. We can see surgery as a sentinel event, something where a patient maybe has the first contact with a doctor. We identify their comorbid disease. I mean, I don't know about you, but I can think of many occasions where I diagnosed either chronic obstructive pulmonary disease or diabetes in a patient on the day of surgery where it had never been detected before. What do we do with those patients? It's very difficult to get those diseases sorted out. And so we miss opportunities for secondary prevention of disease, ischemic heart disease, or whatever it might be. And so we need to take those opportunities to improve the patient's long-term health. Can we predict poor surgical outcomes to stratify patients into the high risk, the intermediate risk, and the low risk, and make sure that we channel our resources at the highest risk patient? And any hospital where you do cardiac surgery, think about your major, you know, colorectal surgery and compare those patients to your major cardiac surgery and what level of resources those patients get. And in most countries, cardiac surgery gets a lot more resource in terms of improving patient outcomes than cancer surgery does, and you know, orthopedic surgery do. And why is that? Well, the reason is because all of the cardiac surgical patients are high risk, and it's quite easy to tailor the system for them, whereas only a small proportion of cancer surgery and orthopedic surgery patients are high risk. And so it's much harder to get that system tailored to individual patients. So stratifying risk may help. Thinking about decision-making, we in the UK are strongly encouraged to make shared decisions with our patients. But it turns out that our patients aren't really thinking about the problem in the way that we think about the problem. The patient tends to be very problem-focused. If they've got osteoarthritis of the hip, they're in pain. They want that problem solved. They don't really want to hear bad news about their operative risk of their comorbidities or their age. You're the doctor. If I'm high risk, fix it. Fix me. I'm in pain. So they just want solutions, not really problems. And they tend to significantly underestimate the risk of poor outcomes compared to doctors, even doctors who aren't well educated in the issues of perioperative medicine and perioperative care. So that tells us that we've got a real problem in educating our patients, and therefore the whole of society, given how many people have surgery, about what can we actually achieve with surgery. So we have to fix something here. We either have to educate our patients and get them to have realistic expectations of what we can do, or we have to fix the system so that we're offering them the opportunity they believe we should offer them. At the moment, I don't really think we're doing either. During surgery, well, you know, we give lots of very, very powerful drugs during surgery. What do we do to optimize patient outcomes after muscle relaxant drugs? How do we reverse them, and so on? You know, simple things about how we set up our ventilators during surgery so that we don't cause ventilator-induced lung injury. There are all sorts of opportunities here to modify patient care to improve patient outcomes. Early after surgery, I think a focus around critical care technology that's simplified so it can be given at scale at a much more cost-effective way. We have struggled to show a benefit of ICU provision in terms of patient mortality, but that probably is because we're comparing intensive care to normal ward care, what we might call in North America, or the floor. And that standard care is very, very variable. In some hospitals, there's lots of nurses, and in other hospitals, there aren't very many nurses at all. And so the great thing about intensive care is it's very well provided for in terms of staff. And in particular, in intensive care, you have very capable, very talented nursing staff who are empowered to lead patient care, and they have very easy access to a doctor who understands their job, and that doctor sees their role as supporting that nurse. And that doesn't happen much in other parts of the hospital, and that may be the magic of intensive care for surgical patients. It's not about organ support, it's not about invasive ventilation or renal replacement therapy or inotropes. It's about really amazing nursing care. Now, technically, we could give that amazing nursing care in any part of the hospital if the nurses were well trained and well supported. And so we need to think about that, because that may be the key to scaling up perioperative care. And then don't forget this later follow-up. You know, if a patient has had an unusual harm experience during the perioperative care, during surgery, do we follow them up? Do we check their acute kidney injury has resolved and refer them to a nephrologist if not? If we diagnose chronic obstructive pulmonary disease, do we make sure that they see a respiratory physician afterwards? All of those kinds of things that we can tidy up. So to summarize perioperative medicine, personally, I believe it will have a very significant impact on society in time, but that may take a long time. It will focus on the entire perioperative period, from the moment surgery is contemplated, and that may well be a primary care physician referring the patient into hospital, all the way through to maybe 3 or even 6 months after surgery. That's the full breadth of the perioperative period. It will become the dominant approach worldwide as more and more people realize that if we are to ensure surgery remains effective, we have to prevent surgical complications and ensure that patients get both the quantity and quality of life they expect from this surgical treatment. And that may well involve educating our colleagues, anaesthetists, surgeons, about the importance of perioperative medicine. A lot of anaesthetists are very reluctant to do perioperative medicine. They don't see it as their job. A lot of surgeons just want somebody to do it for them so they don't have to bother. And, you know, other physicians maybe don't see that as a big interest for themselves. Some do, some don't. And also educate society about what surgery can achieve from them as individuals. And so we will encounter challenges if we continue to pursue this concept of surgery for all, that everybody should have access to surgical treatment if they need it, and that age or comorbid disease should not be a barrier. That's fine as a concept, but if it were me, if it were my loved ones, I would not want them to be offered surgery regardless of the risk. I would want their perioperative care, their surgical options tailored to their risk, so that they were not offered surgery that exposed them to harm. And I'll tell you now very briefly a personal story about my father-in-law, my wife's father, who was in his 80s. He had a problem with his mitral valve that needed to be repaired. He had very mild dementia, very, very mild. You wouldn't notice it. We would notice because we knew him, but he was very mild. He was a retired professor of surgery, believed strongly in surgery as the treatment that could make him better. He didn't like having heart failure, and he knew it would kill him eventually, and he didn't want that. He wanted to be fixed. So he had surgery, and it was an excellent procedure. It was very, very successful, a great surgeon. The repair went perfectly. But after surgery, things just weren't quite right. He was a little bit stuck on a ventilator, took a few days to come off. Then he got acute kidney injury. He had to go back to intensive care. He ended up having renal replacement therapy, spent a long time in intensive care. And overall, he was in hospital for 3 months after this procedure. He eventually got home, was very frail, was slowly recovering, still needed a frame to walk around, but was improving. And then sadly, he had a stroke, had some very severe seizures, and he didn't recover from them, and eventually was admitted to hospital again. And after about another 3 months of being in hospital with repeated seizures, it was decided that we should give him palliative care and allow him to die with comfort and dignity. So of the 9 months after surgery, he spent about 2 or 3 at home, and that quality of life he had was not great. So the question I would ask all of you is, did he make the right decision? Did he have the right information? And was surgery really the treatment that offered him the best benefit? Would he have lived longer? Would he have had a better quality of life if he had elected for a conservative treatment and accepted he would die from his heart failure? I don't know, none of us know, but it's a real story about a real person, and there are stories like this happening today in your hospital and in my hospital and hospitals around the world, and that is why we need perioperative medicine. Thank you very much.
Thank you, Dr. Pierce. We have now a presentation from Dr. Stefani, please. You have to turn on the microphone.
Thank you, Flavia and Rupert, for your brilliant presentation. So in the next 5 minutes, I want to present some of our results regarding a pathway for high-risk surgical patients that we develop in our hospital. So we operate very high-risk patients in our hospital, in our public health system. And our rationale is if high-risk surgical patients are identified, efforts to increase vigilance can be implemented, complications are detected, and escalation of care are provided, and we can reduce morbid mortality. So since 2015, we started work with risk models to identify this high-risk population in our public health system. In 2018, we started a quality improvement project in our recovery room, classificating the patients. And in 2019, we started a quality improvement in our surgical wards. And the results were recently published. And we did a quality improvement program, and this program was supported by our hospital direction, the quality improvement team, the surgical department, internal medicine, cardiology, and nursing service, especially from the recovery room and from the surgical wards. We compared two cohorts in this before and after analysis, where we aim to assess the effectiveness of a post-operative 48-hour pathway for high-risk surgical patients, which we called high-risk surgical bundle in our hospital, HCPA. This bundle was designed to include only high-risk surgical patients that were admitted at the recovery room after surgery and after to the common surgical ward. This group did not meet the criteria for elective admission to intensive care, or they were submitted to urgent procedures without an ICU place after surgery. This bundle is comprised of 6 elements. First, we identify the risk of the patients, and we communicate the risk. And after we adopt a customized handover for these patients from the recovery room to the surgical ward. And we had the prompt nursing admission at the surgical ward. We also had the identification of the vital signs. Instead of each 6 hours, we check the vital signs each 3 hours for this high-risk group. And also have the intensification of medical assistance and prompt access to clinical support if deterioration was detected. Also, we measured troponin in this group. Our primary outcome was in-hospital mortality. And we have some results. Our intervention group submitted to this high-risk pathway. We had 443 patients, and we compared this group with the usual care, 746 patients. We have a high mortality in our usual care, 10.5%. This was in-hospital mortality. You have to remember that this is a very high-risk group of patients, but with the intervention, we reduced the mortality to 6.4. Also, we had increase of rapid response team and surgical reintervention in this group. After adjustment for other variables associated with mortality, we still have a very good the intervention reduced the mortality with a relative risk of 0.46. Our quality improvement program was considered a complex intervention, and sometimes what is planned in this quality improvement program is not exactly what is delivered, but we had high compliance rates, more than 95% of majority of our steps. So to wrap up, we understand many limitations of this kind of study, but we believe that our high-risk bundle can be a template that could contribute to reduce preventable deaths for high-risk surgical patients, especially for these places with scarce critical care resources. This was my presentation.
Thank you, Luciana. At this point, we do not have any questions from the audience, so we can go ahead for the comments and questions from our panel discussion group. Please go ahead.
Hi, maybe I can start. We have a very short period of time. I was just comment that probably we need another grand round just to discuss with our outstanding speakers today, because we are taking notes and going on what we can do in our setting to improve perioperative care. But as a cardiologist, I'll go back and I will ask Flavia and Dr. Hubert about the role of non-invasive tests in the perioperative care. We've been dealing with that in the cardiology field for the last 20 years. Lately, we've called this low-value care for most of surgeries. We know that troponins are better risk qualifier for most of the patients, but what's your opinion? What do you give as an advice for our physicians? How and when we should use this non-invasive cardiac test to identify high-risk patients?
Rupert, do you want to go ahead? Or?
Well, you go first, Flavia.
Okay, I can tell what we are doing. So we're following the Canadian guidelines, and the Canadian guidelines for perioperative non-cardiac surgery, they basically advise biomarkers. So we do preoperative NT-proBNP in our clinic, and we guide our care by NT-proBNP. So basically, I would say for a patient that doesn't have active cardiovascular symptoms, even if they have low functional capacity, and this can generate a little bit of debate with the US guidelines, but we do NT-proBNP because it has a very good predictive marker of who is going to develop myocardial injury and cardiovascular death after surgery. It's better than the RCRI. It adds up on the RCRI. And basically, we use the thresholds that we publish in the annals on a 10,000 cohort that levels greater than 200 of NT-proBNP are patients with a high risk, where we just suggest post-operative monitoring. So we don't do any stress tests. We just send them to do troponins after surgery. We do ECG. We follow all those patients. We put some on telemetry. And if they're greater than 1,500 NT-proBNP pre-op, we send them to monitor in CCU. So basically, the test is to guide post-operative monitoring as opposed to do further tests. And of course, there's individual, patients that they have symptoms that is different. But Carizi, I would say, like I'm at McMaster like for 7 years doing clinic right now. I think we ordered 10 cases for pre-operative cardiac stress tests before surgery. I would say most of them, we don't do it.
So I would say it depends whether you can actually change care with the test. It's no point knowing that the patient's high risk of complications if you just do the same thing that you were going to do anyway. If you're going to do the same operation with the same perioperative care and send the patient home in the same way, then, why not just roll the dice? So you need to be sure that whatever test you do can actually change patient care. That's the first principle. And of course, cardiology has led the world in that logic. And I think we need to learn from that. And the second thing I'd say, it's about scalability. What we have a tendency to do, I'm not sure necessarily at McMaster, but in many other hospitals around the world, is identify a high-risk patient and then test them to see if they're high risk. And guess what they are? So that's no real surprise there. Then And maybe, again, we just sort of use that as a confirmation bias that the patient should have the care that we're going to give them anyway, but it tends not to result in a cancellation of surgery and so on. So I would like to see tests, like NT-Pro or other tests as well that look at other organ systems, although NT-Pro, I suspect, will tell you things about other complications too that aren't cardiac, that can be offered at scale to all patients, not just the ones we think are high risk. And then you probably need a second tier of tests that may be a little bit more time consuming to do that evaluate that risk. So are they high risk? What is the nature of that risk? And then use both sets of information to tailor the care to the individual patient, both in perioperative care, in the hospital, and after they go home. And at the moment, I don't really think any country is doing that at all, and very, very few hospitals, if any. So it's a big, big ambition that's a long way away. And as I say, the test without the treatment, So that's not really a very good answer, I'm afraid, Carisi, but I hope it's of help.
No, that was great. We need to be aware of all this information and change our practices.
I want to thank the speakers. The talks were very insightful. We are running out of time, but I just want to ask a question. How should we, as a hospital, measure if we are improving our perioperative care? Which targets should we follow as an institution?
Go ahead, Flavia.
Thank you. So I think there are several outcomes, and we try to focus in patient-important outcomes. So usually things that we care is about decreasing hospital readmission and ED visits, because we know that patients, they're very afraid to go back to a re-hospitalization after surgery, and we know that this change care. So this is one of the markers that we look into. We also, of course, we look into mortality, 30-day mortality, but as Hooper was saying, like, mortality is not that important if you're alive and with poor quality of life. So we also look into quality of life, and there's several different scores that you can use. We usually do EQ5D, and we do at baseline at 30 days or 90 days. But this is something that we do a lot for all the research that we are doing. So now for any research that we are doing, we collect quality of life, mortality, readmission, but not, I would say, Miguel, as a whole for all patients that comes in the institution, because we work very closely patients that are in research and in clinical care. But these are some variables that I think it's really important. And then sometimes it depends on the type of surgery that you're going to have some specific outcomes for that population. But these are some that I would use as a whole, I would say.
I would agree with all of that. I would say that you need patient-reported outcomes. If you aren't measuring anything, I would agree with Flavia that EQ5D is a good place to start. It's simple, it's translatable, and it's relatively easy to collect at scale, and it's generalizable to all patient groups. So that's great. There will, of course, be some patient-reported outcome measures that are surgery-specific, but what we find is in perioperative medicine is there are lots of patients who fall between the gaps. They may measure the success of that particular surgeon's keynote operation, but that other patient is having an unusual procedure. There's no score for that, and so they don't look at them. But often those unusual patients have poor outcomes. So we need something that you can offer to everybody, but we also need disease-specific, surgery-specific problems as well, where they exist and are relevant. So I think those two things, I would suggest that they're measured not just at 30 days, but at 6 months or even a year if you can, to make sure that success of surgery is sustained. So I think that's has surgery worked for me? Has it given me the quality of life I'm looking for? Secondly, I think you do measure mortality, but not for success. patients don't go into having surgery to be alive 30 days later. They don't see that as success. They see not being alive as failure. And we need to sort of flip it round and see mortality as a measure of harm. And as a measure of harm, mortality is a very important thing to measure at 30 days, at 6 months, or 1 year. And I would suggest we measure that too. And if you can, complications. But obviously you have to be very careful if you want to collect data at scale of being very, very strict about only having a small amount and collecting a small amount well rather than a huge amount badly, because missing data, you know, is very unhelpful for you.
Thank you.
Dr. Russell?
Well, I don't know if we have time, but perhaps a little comment on the challenges to put so different heterogeneous views within a large institution like ours, to get people to work as a team and build up that mentality and change the culture. So I think that Dr. Stefani has showed is a very important little baby step towards something very important to get close to what you guys are doing. So I take this grand round activity here today as a point for us to think about what are we doing here as an institution. I'm just saying that we learned a lot from you, and also we like to hear the big barriers that were found at McMaster, at your institution, Dr. Pierce, to get this thing going, because this is not simple steps. You know, we have so many teams, and having everyone to see the patient as the center of our attention, and despite what we may think individually and change practices, it's a major issue, and it's a daily work for all of us. So Pepe, Flavia, like, you would pick one challenge that you found like the most difficult thing to get your team to work. You build up a new division, I understand. This is a major, so it means that your institution set up as a high priority. You build up a new division.
Yeah, so I would say people are the biggest challenge.
Always.
So, and it didn't come from the surgeons. We start to present to the surgeons, do you think this would be a good idea? And if so, how would you like it to work? And what do you want from us? So we met all the surgical teams, urology, gyne-onc, ortho, thoracic surgery, and they were super happy. I would say the challenge was to integrate the clinical teams, because to integrate cardiology, internal medicine, and thrombosis, that's very strong team in Canada, was a challenge. And we were saying, we're not proposing a new team. The team is us. So if you think this is important, why don't you do the teams with us? So you're being invited to, and then you can be a professor of the division. And when you decide to do your clinical service, you're going to do weeks or months in cardiology, and a few months is going to be peri-op. And then people start to understand that we were proposing a teamwork, and the team were us, not other people coming from a different place, you know. But I think people were the biggest challenge, I would say, that we had.
Yeah, I would agree. I mean, what Flavia's really talking about, behavior change for our colleagues. And behavior change is, behavior change is driven by lots of things. A great way to get surgeon A to want perioperative medicine is to give it to surgeon B. Because once the surgeon realizes that the surgeon next door is getting more care, they will want it. So, you know, the doctors are competitive. It's maybe seems silly, but it's important, because the surgeon, we tease them, I know, that they are the most powerful advocate for the patient. They are very powerful. They carry a huge authority in our world. And if they want perioperative medicine, it's much more likely to happen. I mean, that's the very first thing. Second thing is data. I can sit here and express all the opinion I like, but if I show numbers and prove that outcomes in my hospital are not as good as outcomes in your hospital, people will want to know why, and you can't get round data. And so I think collecting data and comparing data and identifying reasons why data are variable is a really powerful long-term driver. And I think that's why, Jose, your question is so important. And then I think the final thing is patience. We are trying to completely transform a very large, very complex organic system that changes hour by hour, day by day. There is no surgical pathway. If you try and map the surgical pathways in your hospital, you will find it differs by specialty, by procedure, by surgeon, and by patient. And it continually evolves all the time. And so we need something that's flexible and organic to tackle that organic problem. And that will take time. And so we need to be prepared to run a marathon, not to run a sprint.
Thank you.
I think we are almost finishing this meeting, but I was very impressed with the data that was provided by Dr. Percy about dementia associated to almost 50% death rate after 2 years. I'd like to know if it is related to the CNS disease itself or it's a bias associated to the comorbidities, Dr. Percy.
The short answer is we don't know. We can speculate on the biology of what's happening, but this was all surgery. It wasn't one particular type of surgery or a small range of surgeries. It was all surgery, intermediate, minor, major, and I think, therefore, the dominant feature is that there are certain comorbid diseases that will dominate the patient's survival, and surgery won't make much impact on that survival in the presence of that disease. That, for dementia, would be my guess. For other diseases, I think it will be different, but it becomes really complex when you start to look at interactions of diseases. And there are certain diseases that interact in a particularly bad way, and other diseases that don't interact at all, and nothing seems to happen. And the patient remains very low risk, even despite the presence of 2 or even 3 diseases. And so we've got a lot of work to do to understand actually what happens as a result of these different diseases, in order to come up with scalable solutions. Because what tends to happen is individual doctors, we go and see a patient and we're very, very good at analysing all of this information, very complex stuff, and saying this patient is high risk, this patient needs extra care. And we're very accurate in those assessments that are qualitative, not quantitative. The problem comes when you want to do that for thousands of patients, or tens of thousands that you may see each year. And that becomes much, much harder to give that very quality assessment.
Okay, thank you very much. I will ask Dr. Stefania to make the closing remarks, as she was responsible for this meeting today. Go ahead.
Okay, thank you, James. So I'd like to thank you so much, Flavia and Rupert, for being here with us today. I'm receiving lots of comments by lots of colleagues from surgical and clinical. So thank you so much, and we hope you can meet again soon. Thank you.
Thank you for the kind of
Wonderful. Thanks, everyone.
Thank you all.
Take care.
Bye-bye.
Bye.
Thank you.
Foi bom, né?